Hi, I'm Dr. Swati, Ayurveda gynecologist at Fertility Dost. I hope I'm audible. Today I'm here to talk about how female hormones affect the fertility levels and how important it is to get tested female hormones and what are these female hormones. To begin with, the female hormones which are responsible to understand the ovarian reserve or the ovulatory functions. So ovulatory functions means that's a function of the ovary, that is to release one mature egg every month for an healthy conception and for healthy fertilization and an healthy conception. So the hormones which are important are follicle stimulating hormone called as FSH, LH, that's the luteinizing hormone, progesterone, estrogen, AMH, inhibin B. So these are the hormones which help us to detect ovulation and also the ovarian reserve. So there is an inverse relationship between the female age and fertility. That means as the um, age advances, fertility level decreases. So if we see the statistics, the overall miscarriage risk in an older woman of age 40 is somewhere between 50 to 75%. So, for these reason, starting at the age of 35, testing is strongly advised, or the hormonal testing is strongly advised, or even after 6 months of couples who are desiring for conception. So we can understand them as a two rules where at the after the age of 35 hormonal assessment is very much mandatory, and if you're trying for about 6 months and if there is no result, then hormonal assessment is needed to understand the ovarian function and also the ovarian reserve. So, as I said, ovarian reserve is inversely proportional to the age, but ovarian reserve can also be lost because of various other reasons as well. So, as a result, testing should be done mandatorily. Currently, in the if we see going for an FSH and an estradiol level is one of the most cost effective approach, and along with going with FSH and estradiol, testing for the hormones like thyroid stimulating hormone, that is a TSH level, and prolactin levels, that's a disturbed thyroid stimulating hormones or dearranged thyroid levels and raised prolactin levels can also affect ovulation, or it is been directly associated with ovulatory dysfunction. So now let us talk or discuss about these each hormones and when it is ideally advised and their almost values. So first I would like to talk about the ovarian hormones, that is the serum progesterone and the estradiol. So ovulation is tested by measuring the mid luteal phase of progesterone, that's during the mid cycle. The progesterone is serum is taken to detect the value of progesterone. So if you understand, or if it is a classic 28-day menstrual cycle, on the day of 21 following the first day of period, so Day 1 is the day when you started bleeding, and on the day 21, serum is drawn to check for the progesterone level in the blood. So if the value is more than 9.4 nanogram per ml, then it has a prediction of higher pregnancy rate. That means the values of progesterone on day 21 should be more than 9 nanogram per ml. This indicates that the pregnancy rate in that cycle is way too high. So similarly, if we see with the estradiol, progesterone, as I said, it should be done on day 21 for a better understanding of the ovulation, and estradiol is done on day 3 of the cycle, or we usually call it as day 3 estradiol level. In case if the day 3 estradiol level is more than 80 picogram per ml, it is considered as abnormal, and day 3 estradiol level more than 80 picogram per ml is considered as abnormal. So now let us also discuss about the FSH. So FSH is the follicle stimulating hormone. As the name suggests, it helps in stimulating the follicles every month. So FSH is ideally done in the early phase of menstruation, that's on the day 2 or day 3 of the cycle. So an FSH level more than 10 milli international unit per ml will indicate significant loss of ovarian reserve. That means we want our FSH value to be less than 10 milli international per unit per ml. The more, the higher the values of FSH will indicate your ovarian reserve is reduced or it is weaning. So this gives us an basic idea on how intensive or aggressive treatment is needed in regard for the planning of conception. So FSH and estradiol hormones may vary from one laboratory to another laboratory. So these things also should be kept in mind. So the next important hormone which I want to talk about is the AMH. That's the anti-Mullerian hormone. So here the factor to be analyzed is it's a predictor of ovarian reserve. So the AMH value gives us an idea about how much reserve the ovary has. We see in our regular practice that AMH is increased 2 to 3 fold in the diseases like PCOD. So, in the diseases like PCOD, it is very normal to see the AMH value in range between 9, 14, 10. That does not mean the ovarian value, ovarian reserve is good. That's an abnormal range here. So AMH value has an advantage over FSH and estradiol, whereas FSH and estradiol is excuse me, yeah, also helps in analyzing the ovarian reserve, but the condition or but the prerequisite what we need to go for an FSH and estradiol is only on day 3 of your cycle, whereas AMH holds an upper hand in this regard because this hormone expression is independent of the cycle stage. So during any time of your cycle you can go for an AMH level, and it gives the values of, or it gives a range of the ovarian reserve what is present. And one more advantage what an AMH value has is AMH value may drop prior to the drop seen in FSH and estradiol level, because these three hormones also help in understanding the ovarian reserve itself basically. So why do we have different tests? We can go with FSH and estradiol. As I said, it's cost effective and very easily done. But AMH drop prior to observable change in the FSH and estradiol, whereas we can take action quickly in regarding to the depleting ovarian function. So the hormones which affect are, again I want to summarize, that's FSH, estradiol, progesterone, thyroid stimulating hormone, prolactin levels, and AMH values. So if we see where are they released from, so now anterior pituitary, which is located in the brain, it releases follicle stimulating hormone and luteinizing hormone. Ovary releases estrogen and progesterone. So it's a vicious cycle which between, or the interaction between the brain, ovary, and the endometrium. So it works on negative and a positive feedback. Like estrogen has a negative feedback with the release of follicle stimulating hormone. That means in the first half of the cycle. Second half of the cycle, progesterone is released on the basis of LH surge. That's 48 hours prior to ovulation. LH surge is noticed. So, which is most ovulation kit predict because of this LH surge in the urine. So, LH surge happens preceding we notice ovulation. So these hormones are at most important, and going for these hormonal investigation at the right time is also at most important. Going at any random day of your cycle is not going to give the desired result, or it may confuse, or you may end in a dilemma. So always go for FSH, LH, estradiol on day 3 of your cycle, day 21 of your cycle to be advised for progesterone hormone. AMH hormone, you can get it done on any day of your menstrual cycle. I hope the hormones and their values are clear. And let us check with the few questions. We have a question like, is it really important to know the FSH value along with AMH? So AMH is going to give us ovarian reserve any time of the month. Sometimes it happens that we see a patient in between the cycle and there is no much time, or any reasons we won't be able to wait till the day 2 or day 3 of your cycle. In case if the cycles are irregular, we cannot predict the cycle. In such cases, AMH has an upper hand to understand the ovarian reserve, and FSH value gives you the ovarian reserve rightly only done on day 2. Now, going for both FSH and AMH in the same cycle again will give you a better understanding, I would say. So, if you have to get both, it's well and good. If not, going for an AMH on any day of your cycle will also give understanding of how good your ovarian reserve is. Yes. So, do we have any more questions? So, if you have any more questions, please put it in the comment box. And as I said, the point to remember here is the FSH and estradiol values may vary from one laboratory to another laboratory. So, this thing also should be kept in the mind. I've yeah, could this value fluctuation means infertility? So yeah, FSH value more than 10, as I said, FSH value which is more than 10 milli international per unit per ml. In case if it is more than 10, then that means it is a depleting ovarian reserve. So, as such, in if we get this task done in the menopause or premature ovarian failure, we see then FSH doubled like 3 to 5 times. So that means the ovarian reserve is depleted. But as such, in case if it is more than 10, we can understand that the ovarian reserve is depleting and aggressive treatment should be started. Yeah. Estradiol more than 80 picogram per ml indicates abnormal value. AMH normal value is somewhere between 1 to 3. But in PCO conditions like PCOD, we see 2 to 3 fold of increase in the AMH values. Serum progesterone done on day 21 value should be greater than 9.4 nanogram per ml, and this value gives us an indication of high pregnancy rate. So that's the reason when you're trying to conceive post ovulation, you are advised with the progesterone pill, so that the progesterone hormones is directly, or the progesterone, the greater level of progesterone hormones is a greater success. So the greater the value gives you the more success. The value greater than 9.4 nanogram. That does not mean the value should be somewhere around 100, but more than 9.4 nanogram per ml gives a higher pregnancy rate. So, yeah, one more interesting question what I have here in the comment box is higher values of AMH indicates PCOS. So, can we reduce this? Yes. So, now why there is an higher value of AMH in PCOS is because of peripherally placed follicles and the bulkiness of the ovary. If we work on this part specifically, we will be able to reduce the level of AMH and also improve eggs. So we will be able to achieve this. Yes. The though AMH is increased in PCOS, there are many other associated complaints as well. There may be anovulation, or she may not be ovulating every month, and or she may be having amenorrhea, or they may be biochemical or classical features of increased hair growth in the upper lip and the chin, or in the ultrasound you see the characteristic features of PCOS. So either of these three either of out of these three, two things are mandatory to diagnose PCOD. AMH we can understand as one of the factor which understands with PCOD, where we say it as it is 2 to 3 times increased value. Yes. So, friends, if you have any more question, please drop it in the comment box. And you can also ask questions or DMS through our Fertility Dost handle in Instagram and Facebook page. Thank you. Thank you for joining. Thank you.